Okay, good afternoon. Good afternoon, and welcome to the first Philippines Graphic Business Mirror webinar for this year. Today's topic is about how hospitals have been handling COVID-19 patients. I am your host, Anne Ruth de la Cruz, the Wellness Editor of Philippines Graphic. To give the opening remarks for this very timely webinar is the publisher of Philippines Graphic and Business Mirror, Mr. Anthony C. Cabangon.
Good afternoon. Nobody likes going to hospitals, especially if there's a need to be confined for an ailment that requires operation. The hospital became even more frightening because of the COVID-19 pandemic. It practically became a war zone with doctors and medical staff having to don PPEs to ensure their safety. Patients who were diagnosed with COVID-19 had to face the battle alone, as there was a big risk to their companions. Even to this day, when quarantine restrictions have eased a little, people still do not want to visit the hospital, even if heart disease had already set in because of unchecked diabetes or even a lump that was found on the breast turned out to be stage 4 breast cancer. There is fear that there is a big chance of getting COVID-19 if they visit the hospital. This webinar, a project of the Philippines Graphic and Business Mirror, aims to inform you all about what sort of measures the hospitals have adopted in order to make it safe not only for patients but for doctors and allied medical staff as well. You will hear about the innovations that they have made in order to adapt the demands of the new normal. We hope that after this webinar, you will take charge of your health and visit your doctor for health reasons. As someone once said, the hospital might even turn out to be the safest place for you to visit. Thank you.
Thank you so much, Boss Anton, for your message. We have gathered today a very distinguished panel of speakers who will allay all your fears about going to the hospital. Titled Hospital Best Practices in Handling COVID-19 Patients, we have speakers from public and private hospitals who will talk about the protocols they put in place, the innovations they introduced, and how they will be adapting to the new normal. We will also have a special session on how 2 government hospitals continued to care for heart failure patients during the pandemic. 2 special guests will also give their reactions on what they learned from our speakers. To make this webinar more interesting for our viewers, we will have a contest. I will be asking 3 questions during the webinar, and the first 3 persons who will give the correct answers to all 3 questions will win a Bosch bread toaster. To join the contest, please like the Facebook page of Philippines Graphic and send your answers via PM. Shaira Barnuevo, our page administrator, will inform me of our 3 winners at the end of the webinar. To start the ball rolling, allow me to introduce our first speaker. He is a seasoned professional leader manager, thanks to his 20 years of continuous engagement in the healthcare industry, with stints in the largest medical institutions in Manila and Mindanao, like St. Luke's Medical Center in Quezon City, the Medical City, Davao Doctors Hospital, and currently Asian Hospital and Medical Center. Always an optimist, refusing to accept failure as an option, and is a firm believer in man's unlimited ability to reach beyond his grasp. To speak about Asian Hospital in the next normal, here is Mr. Andres M. Licaros Jr., the President and CEO of Asian Hospital and Medical Center. Sir Andy?
be here today to share with you our experience and the lessons we learned from the early days of the pandemic until today. For over a year now and counting, the challenges COVID-19 presents continue to be full of uncertainties. While the vaccines have been developed very quickly and in record time, the virus sustained its ability to adapt, mutate, and continue to threaten communities everywhere in the world that remain vulnerable and complacent. Asian has always taken pride in its ability to cope up with crisis after crisis. After all, this institution was founded 18 years ago, right in the middle of the 1997 Asian financial crisis, but has weathered the birth pains of putting up a greenfield healthcare facility that changed the landscape of all healthcare providers in Manila in May 2002. And since Metro Pacific acquired Asian in December 2011, we have grown consistently in census and revenue, driven by the creation of the most comprehensive provisioning of solutions to the most complex disease burdens confronting the fast aging population here in the South. Then the pandemic struck with agility and firm determination to take on all comers by our way of consistent display of our firm resolve to take care of and save as many lives as we can, even at the height of the two surges in March and July. Asian proudly stands by the outstanding outcomes we achieved in making every patient who came to us feel better as we make them well. And a year into this pandemic, a lot has changed in the way we conduct our daily lives. All of us here, we miss the freedom to move around in our community without the need to wear a mask, shake hands with our neighbor, hug our relatives, or even dine in public with our friends and family members. But the truth is, the virus is still active in our communities, and the vaccination program still waiting to be rolled out in the country. This situation will continue to be our normal, our new way of living. My next slide, please. One of the key truths of the pandemic, just like any disease burden, the virus does not discriminate. We see the number of cases around the world continue to climb in certain areas. And here in our country, while we still experience surges of cases in different provinces, it has somehow abated in Metro Manila. And among the many realizations brought by the pandemic, the following seem to resonate well with us. First is that our grandparents were right all along. I remember as a boy how strict my grandmother is. You're not allowed to eat without washing your hands, and you wash your hands after eating. You're not allowed to constantly touch your face. You either use a handkerchief or a towel and to wipe your hands first. And you're always told to cover your mouth when you cough or you sneeze. And these are basic decorums of our youth, but are now the safety protocols that we lean on, and reminders of world agencies such as the Center for Disease Control, the World Health Organization, and even our own Department of Health continues to espouse this. The WHO has a long-standing program on hand washing. All hospitals take pride that every 8 o'clock or 4 o'clock, we develop that habit to remind us to wash our hands to save lives. These days, you have wearables like Apple Watches that can be configured to have hand washing reminders to allow us to wash our hands for at least 20 seconds to secure that it is thoroughly clean. I have two grandsons, one 6, one 4. And I know when they're washing their hands because someone is singing happy birthday inside the washroom. And they're very disciplined about it. In line with this is the importance of taking care of our health. The second learning is that Being healthy is our best guard or safeguard against the virus or any disease for that matter. Being forced to stay at home has somehow enabled us to relearn the value of cooking meals at home and maintaining a healthy lifestyle and have time for exercises. For the first time in a long, long time, I'm able to use my rowing machine and hit at it every afternoon, and it has helped me a lot. This is also the time when we are reminded that wellness checkups are as important as your regular checkups for those who have chronic diseases. In the decades that I've been in the industry, I've known this all along. People only come to the hospital when they feel something they cannot understand and they need help. But I've always believed you come to the hospital when you're feeling well so that you get good screening tests, so that you know how well you are doing, and you prevent yourself from coming to us when you're in a bigger problem. These consultations should not be delayed because these are our guide in ensuring that our immune systems are strong and that we are on top of our health in fighting off any virus. And lastly, as part of the hospital management, everyone now learn that you have to think better, think harder, and rethink how we provision our services to our patients. Given the restrictions in the communities with all these lockdowns and the growing healthcare needs, we have thought of innovative ways on how to continue to provide the services to the community so that the treatments and consultations will not be delayed. New ways to move around. There are some, these are some of the new ways that this pandemic has changed. We have redefined how we interact with each other, even in how we greet each other. Since we cannot shake hands, hug, or give high fives, we have developed new ways of greeting, of doing this without the need for physical contact. I have another grandchild. She's only 11 months old, but she's already being taught sign language. And I would imagine that would come handy in a normal situation that we have now, where it's safer not to open your mouth, but probably communicate using signs. We realize that we are all connected and we can only fight off this virus if we work together in keeping each other safe. All establishments, hospitals included, mandate us to answer the health declaration form for us to be mindful of our health when we do our errands. However, nowadays we seldom fill out papers anymore. We see a lot of QR codes in entrances and we use technology to answer. QR codes have been there for the longest time, but we have not leveraged its full utility. It enables contact tracing faster and more efficient, and even those who are not tech savvy are taught on how to use digital platforms to go about their businesses. In Asian Hospital, our next slide, please. We have launched our Tag Safe campaign to promote the safety protocols in all our clinics and departments. We have implemented various communication activities to make sure that everyone in the hospital is aware and strictly abides by our safety protocols. This way, it is easier for our staff and doctors to promote these protocols to our patients and guests too. The consistent implementation of new ways of moving around provides assurance to our patients that our hospital is a safe facility for both well and sick patients. Even the patient flow inside the hospital has been redefined to ensure that there is physical segregation between COVID and non-COVID patients. We have very distinct hot and cold zones. Hot zone referring to the COVID zone. This also provides confidence to our healthcare providers that the infection is strictly contained and that they are also safe while they continue to provide the best care for our patients. As an administrator, I recognized that early on. No matter how good our heart is wanting to save as many lives, we cannot save them if we do not save ourselves. So we put premium and priority in protecting our healthcare workers. Another change brought by the pandemic is the transition of care from purely manual to automated or digital. These are some of the new ways of doing business that shifted last year. When you think about it, we've been so comfortable in the old structure, and I've always described it. Everyone says they want to be patient centric, but in truth, the payer is being tossed around the hospital, moving around, filling out forms, and always waiting. We have been forced by the pandemic to create a digital space for our doctors to practice, and that is our e-consult platform, where patients can continue to engage with their doctors and for our staff to be more efficient. A great challenge in healthcare is during the lockdown is how to continue to safely provide the services to the patients needing them. Patients needing urgent and emergency care, of course, has to go to the emergency room so they can be treated immediately. But in truth, there's technology that can provide uh, urgent care in real time from anywhere. And we're seriously pursuing that to make sure that all options are available so that patients coming to us only come to us when really, really necessary. However, for the other services we have developed, uh, e-consults and our online appointment system, I believe before the pandemic, doctors and patients are not used to setting appointments. Everyone just come on demand when they feel like they need it. But because it's unpredictable, more often than not, you fall in line. But doing an appointment system makes it more efficient. And foremost, it allows you a minimum stay inside the hospital to be with people that are not within your bubble. This enabled our community of patients to continue their treatments in a very safe environment. Our specialist doctors are decked in our e-consults platform and are ready to be consulted online. Our online appointment system, on the other hand, enables patients to schedule and settle their payments before going to the hospital so that their stay in the hospital is short and safe. Online payment system or a cashless payment system is safe. And it's ironic that we used to do this when we book our travels. We've been traveling a lot before the pandemic. When you book the restaurants, when you book the hotels, you do this online. But for healthcare, where it promotes and delivers and creates greater value as far as safety is concerned, it has to wait for a pandemic to get it done. We have actually launched the version 2 already this week as an improvement to the first version launched May last year at the height of the pandemic. Doctors' consultations and appointment systems, however, are not the only tools that have been converted to digital. All meetings, conferences, training sessions have gone virtual. I have not met anyone face to face for the longest time now. Even if we are all in the hospital, we have been prudent and we do meet using the technology, using Zoom, MS Teams, or other platforms. We have re-engineered our services to be closer to our community by being more accessible. This webinar is an example of how the pandemic has changed how we communicate to a wider audience. It is simpler, more efficient, lower in cost. In Asian Hospital, even in digital format, we continue to try to provide the same compassionate service to our patients without breaking our safety protocols. An example of this is our eConnect or the virtual visits. We know that the family of our COVID patients need constant updates on the well-being of their loved ones. So instead of just calling them to provide the updates, we have made our family conferences virtual by connecting them through video conferencing tools, such that the family members, patient, and the care team can continuously talk to each other, see each other in real time. Together, they discuss the care plan for their patient, and they can see that they can see their patients in real time too. And we all know by now how sad and how lonely it is to be stricken with COVID and deteriorate all the way to critical acute care, needing critical and acute care, and die alone. The most important change the pandemic brought is the new mindset. It has taught us to be forward looking and to be resilient. Filipinos by nature is a resilient race. For us in the hospital, we have envisioned to be a hospital without walls, a provider that is accessible to our patients anywhere, anytime, in a safe environment. Hospitals are a 24 by 7 operations. But when you look at it, at night, most of us are asleep. It's only the nurses and a few senior officers who are in the hospital. But with technology, on very, very critical moments, everyone is really accessible as long as there's internet access in your place. This mindset is being forward looking, enables us to be progressive thinking too. We do not just try to adapt to the current situation, but we are proactive in transitioning to the next normal. And this is where our communities are and where our patients needs us. The digital environment is one of the ways that can streamline our processes and provide better and efficient service to our patients. This means empowering our patients to schedule consultations with doctors through telemedicine, electronic scheduling, and paying for their procedures ahead of their appointments, and allowing them to get the test results digitally in real time. And this can all be done in the safety of their home. Digitalization goes beyond the processes in the hospital. The pandemic has exposed the need to work collaboratively with other healthcare institutions. Networking with the other healthcare providers around us is a must. And our government, to deal with the challenges it has placed on the workforce, supply chains, the infrastructure, among others. The data that will be generated in an electronic format, the health systems can move towards the post-pandemic new reality faster and more efficiently. Access to data has always been difficult, and I've always believed that sharing of the patient records for every patient who is navigating the network of healthcare providers should be possible and should be allowed. Uh, I know that especially for private hospitals, we've been very stingy sharing the patient records because we all desire that the patient will just utilize and engage all the services of the hospital. But I don't think that is fair, and that is what will allow us to improve the outcomes. Digitalization also does not diminish the ability to provide for a compassionate and sometimes personalized touch that we Filipinos are known for. We continue to ensure the programs that we launch provide the most unforgettable healing experience to our patients. Lastly, the pandemic may have halted some of our plans and changed the way we live, but it has also taught us how to be resilient and grateful. It has enabled us to focus on the things that matters most to all of us, which is our family and our health. In doing so, we become mindful of our well-being and helps us adapt to the new requirements of the next normal. With that, maraming salamat po. Thank you for allowing me to share with you our Tag Safe campaign and our next normal protocols. And we are always here to serve, listen, and respond to all your fears, all your doubts. Good afternoon.
I will be asking my first question soon, so please stay tuned. In March 2020, the Department of Health designated the University of the Philippines Philippine General Hospital, UPPGH, as one of the three COVID-19 referral centers in the National Capital Region. The other two being the Jose M. Rodriguez Memorial Hospital in Caloocan City and the Lung Center of the Philippines in Quezon City. To tell us about his learnings from this experience of being a COVID-19 referral center, Here is Dr. Gerardo Gap Legaspi, the director of the Philippine General Hospital. Dr. Gap? Sir, we cannot hear you, sir. Yan,
Yeah,
there you.
am I on?
Yes, sir. Okay na po.
Is my slide on already?
Yan.
There.
Can you? Okay.
So thank you very much. Is my slide on?
Yes, sir. Can you see it, sir?
Yeah, okay. Thank you. Thank you very much for allowing us to share our experience uh, in the Philippine General Hospital. Starting with this picture, one of my favorite pictures during the pandemic, when one of our nurses showed true grit,
Wow.
commitment, coming to work in a hospital provided bicycle means the cars and bus. So I think the story of this pandemic is the story of human spirit. That's what was very evident in a lot of the stories of the accounts of the hospitals that dealt with it. So just to give you a brief background, PGH is 113 years old. It's in 10 hectares of property in Ermita with 23 buildings separate from each other. We are a 1,500 bed hospital and we saw 700,000 patients a year in 2019. Most of our patients are a mix of from immediately around us and from all over the country. The PGH has 4,500 employees. It's a big group of varied personalities to handle. More so added to that are more than 4,000 trainees who pass our halls every year. When the first confirmed case of COVID-19 infection was announced on January 30, so it took probably a month and a half for it to start rising. And we all remember when the lockdown was declared in March 16. And a few days later, I was called by the Secretary of Health, Secretary Francisco Duque, to designate PGH as one of the 3 COVID referral hospitals in the National Capital Region, assigning to us the biggest quadrant, which is the southwestern quadrant of the capital region. So it was a big debate for the university and the hospital whether we should accept the designation or not. But I think it's a moot question to ask because we were determined to play our part in the pandemic. And I think as in any major endeavor, I started the message to our employees and our alumni and everyone who's going to get involved with these operations just to get everyone on the right footing. So it is something that we decided on to do for everyone that has been fighting and of course for all the right reasons that we have to do it. First thing we did was put together a COVID crisis committee management team, which is separate from the management of the hospital. If you are, for the doctors who are familiar with this group of people, these are all surgeons, senior surgeons in our hospital, already famous in their own fields, in trauma, in neurosurgery, in head and neck surgery, urology, colorectal surgery, hepatobiliary surgery, and other specialties as well. I decided to get a team of surgeons who are not afraid to break laws, so to speak, to get things done, because at that time I think it was what was needed, because no one really wrote the playbook on how to run this pandemic. But of course, we had to balance that with our voice of science, the voice of reason, Dr. Nina Pascua Berba, who was the head of our infection control unit. This testosterone-laden table did not move unless this petite doctor told them to do so. I think that's a balance we were able to create, and it afforded us a very quite an efficient way of doing things. So we tried also to keep the organization really simple. I remember writing this on the board, just a few names. This group taking care of the COVID operations, while Dr. Julia Aguilar, who was the health operations deputy director, took care of the rest of the hospital, at least in the time being that we were preparing. So In a more complex diagram later on, we realized this was how it was organized. Although there are separate teams, they are intertwined by common interfaces because of the commonality of resources and processes. So I think the first step that had to be done was really separate the COVID crisis management from the day-to-day operations of the other services of the hospital, which we intended to continue. But later found out that we had to really decrease significantly in the ensuing weeks. So one big challenge was, PGH was designed in the 1910 to be an open ward, the Nightingale type of ward, and there's no negative pressure room in the hospital, and so we had to contend with a lot of infrastructure changes in terms of ventilation, space management. This is how the emergency room looked 2 weeks before the lockdown, and this is how it looked like on the week that we were preparing. So we had to do a lot of distribution and redistribution of patients thanks to the field implementation and coordination team of the DOH, which took most of our patients that were admitted at that time. So we had installed electric motor beds to ease the care of our patients by PPE wearing personnel inside a non-air conditioned but well ventilated room. So we were able to prepare 243 beds, although we promised Secretary Duque 130. We knew that we predicted things were going to escalate, so we almost doubled the capacity in the different areas of the hospital. So there were areas that we separated for non-COVID patients. So on March 30, we opened as the third COVID referral center for the NCR.
Doc, sorry, we can't see your slides po.
Sorry?
We can't see your slides po. Hindi po gumagalaw, sir.
Let me... Hanggang saan nag-stop?
Actually, hindi pa po gumagalaw po. You were talking about the operating room po yata yun, before? Or yung Nightingale setup?
About this one.
Yes, yun na lang po tayo mag-start po.
Can you see this? It's not moving.
It's not po eh.
But it's moving in my...
Wait lang.
Di ba all windows? Let me go back.
It's not moving, sir.
Application window, right? Application window share.
Yes po.
Application window. This one, can you see it now?
Can you see it, Ed? Wait lang, sir. Hindi ko pa nakikita eh. Kita mo, Ed? Wala pa daw, sir. Ayan na po. Yeah, showing na po. There you are.
Is it moving now?
Can you make it sa po? Slideshow po. Hindi po siya naka-slideshow?
Naka-slideshow na siya.
Ba't ganun? Po. Hindi naka-slideshow.
Next slide yan.
Ayan, okay na, sir.
Slideshow na siya ngayon?
Hindi pa po.
Pero nasa third slide.
Pero naka-enlarge naman po yung slide.
There. Wala pa rin.
Wala pa rin? Wala pa rin, sir.
How about this one?
Yan na.
Okay na? Okay na, Ed?
Yan.
Pero hindi siya slideshow.
Next slide na lang.
Next slide na lang po, sir. We can use this frame na lang po. Basta next slide
Ito
na lang.
ayaw. Itong slideshow ayaw.
Ayaw po eh.
Down
Sorry
arrow.
about that. I don't know.
That's okay, sir.
Down arrow.
What's up?
Down
We'll just use this setup na lang, sir.
You know, I sent you my slides.
You did, sir.
Yes,
Sige.
sa email. Maybe you can.
Sige po. I'll try to retrieve it po.
Bakit kaya? I did exactly what.
Pero pag ganyan, sir, can you move forward with it?
Yeah.
We can make, yeah, ganun na lang, sir.
Ganyan na
If
lang.
it's, yeah, if it's okay po with you.
Okay. So I think I was in the part where
Yung Nightingale approach, yung
Yeah,
sinasabi
so-
niyo po. Yeah.
so we started with the message, as I said, that I
Yes.
wrote to the employees, staff, and our doctors to set the ball rolling, and created our crisis management teams. I've shown here the two teams of surgeons and the infectious control head, Dr. Berma. We simplified the organization, and each of this person just chose the team that would run the particular assigned task unit. Dr. Ocampo for operations, Dr. Dennis Serrano for logistics, and Dr. Rodney Dopitas for manpower. Um, the infrastructure changes that we did, as I showed earlier, as I mentioned earlier, had to do with reorganizing space so that we empty our usually full emergency room and wards and make them conducive to taking care of patients, COVID patients, with personnel in full PPE. We were able to prepare 243 beds, although we committed to 130 initially, but we were prepared to scale up anytime the pandemic got out of hand, and it did, for a while, as we all know. So we opened the COVID referral hospital on March 30, 2020, and of course, having laid down the plans for the operations, I had to test it myself by donning the PPE. Every now and then, I'm going into once. I think if there are two innovations that I'd like to share with you, is that how we adopted the ventilatory innovations to make sure that our healthcare workers in the wards are properly protected from aerosol transmission, as well as droplet. So, being a non-negative pressure area, we consulted two architects, and we were given the system of a unidirectional airflow, wherein large fans blew air from the fresh air from the corridors outside into the wards inside the pavilions, and exhaust fans from outside in the windows on the windows sucked in fresh air from the side and blew it, and another series of exhaust fans drew the air into an empty garden in the middle. So this afforded a unilateral flow that, if you see here, we check regularly with these strips of paper that showed that the air is flowing as we planned it to be, from the front going in, and from one side of the ward going to the other. So I think this was proven by the fact, the effectivity of this system was proven by the fact that our infectious control team did a test swab by swabbing all the surfaces in the wards, and they only found out they found the virus to be growing only from the toilet seats in the bathrooms. On the railings, on the floor, on the tables, on the beds, no virus grew. And I think that's all part, of course, effect of all the health protocols that were instituted. And I think another innovation that we thought would have really contributed much to the well-being of our patients is the telekamustahan. It is an online conversation between the relatives and the patient, as mediated by the social worker, and it was oftentimes it was um, emotional, and even the social workers sometimes were driven into tears with the conversations with the patient. So I guess amidst all the things that we have done to improve our system, I think I'd choose these two as the top two as innovations that I think made our lives a lot easier in the wards. No? So having prepared all of those and having been a COVID referral center for 11 months now, let me just share for the next few minutes some of the lessons that we've learned from operating the COVID hospital. No, we are now down to around 75 or 70 patients a day, with 20% in the ICU, down from 220, 240 at our peak in July and August. So all of this we've done based using science as a base for our decisions. So, PGH being a university hospital is steep in research, and there are right now 300 ongoing COVID-related researches, with some of them already published internationally and locally. This has allowed us to standardize the protocols while allowing adjustments for the needs of the different areas as they arise. No? It is not only enough to follow science, but we have to choose the right science. And I'm happy that our experts here guided us well into the safe protocols and the effective interventions for our patients. And we use all of this to manage our fear, which I think was the biggest hindrance to an effective management of the COVID referral hospital. The fear was very evident in everyone's face, including ours probably at the start. But when we believe in real science, in good science, it started to melt away. So one of the things that science proves is that the RT-PCR test is not the end game to the fight against COVID. It's just a point in time, and the reliance on it should be well tempered because the assurance of negativity is brief and only during the time of testing. It was at a certain point it became a privilege for someone to have the RT-PCR test because it was so low in availability, but I think we should remember that the use of such is really to determine a point in time to make decisions based on RT-PCR. Still, whether you're positive or negative, precautions still needed to be observed. And I think this is how we preserve the low infectivity in the hospital, despite the absence of RT-PCR at the start of the pandemic. We also use the RT-PCR to protect the hospital from the community by requiring testing for our patients and their watchers as a common practice nowadays. As I said, testing is a clinical strategy, not a political tool. I think we should know that testing is used to make a clinical decision. We also use it for an opportunity for counseling and education. We did one mass testing of 4,700 employees, and we promised ourselves to never do it again. Although we got a lot of information to that, but it was so it took so much for us to launch that, and I think we have recommended to the Department of Health targeted testing as a more efficient way of utilizing this technology. And what we did, though, was to lower our threshold for testing. The slightest symptoms, we allowed our employees and our workers to have their tests. And also on some personal reasons, especially when for those COVID workers who haven't gone home for months or weeks and want to feel confident going home, we allowed testing for those personnel as well. I think one of the, in conjunction with our mass surveillance testing of 4,700 employees, we also did concomitant rapid antibody tests and found out that it only had 20% sensitivity. I think we published this in the daily papers, and and sent our recommendation on to the Department of Health, which I think started the uh, uh, demise, so to speak, of the non of the rampant non rampant use of rapid antibody tests in the wrong way. Our surveillance showed us that those working in the COVID wards actually had a lower infection than the support staff that were helping them, or those working in the non-COVID wards, or even and just about slightly higher than those working in the offices. So this proves that if you have a health protocols well in place, even in a hospital like PGH with high-risk patients, COVID infection can be brought to a minimum. The other lesson that we learned is that contact tracing is time sensitive. It is very vital to do this to protect the hospital and its employees. The response should be immediate. That's why we made sure that with our infographics, people knew whether high, moderate, or low risk. And because if you delay it even a day, it loses impact in the management of the control of infection. We start quarantine upon identification of a high risk, and we do not wait for test results to come in before we quarantine the employees. I think all hospitals will realize, and the hospital managers will realize that our most valuable resources are still our people. That's why we made sure that we help them manage their fears, again, by using science and, of course, other social interventions. We kept them informed by our infographics that were easily understood. We kept them protected and comfortable with the PPE that is designated for their work area. We provided housing and transport. And I'd like to make special mention of the contributions of Dr. Ed Cabangon on the housing of our of our nurses, COVID nurses in the City State Hotel. Transportation was afforded them, and there was none available from in public. And for so such that in the evolution of our operations in the hospital, our personnel, the doctors, the nurses who were initially soldiers taking orders from their general, became our partners rather than just taking orders. They became partners in a cooperative. So I still find them as the source of my pride and inspiration to this day. So we committed to moving them as much as we could, provide them daily transport. It cost us around almost 200,000 a day in the early parts of the pandemic to move these employees. At a certain point, we housed 1,800 healthcare workers, again at a staggering cost. But thanks to donors like City State, we were able to bring this down to a more manageable rate. So we also, of course, had to attend to the intangibles of taking care of our healthcare workers, no? From moisturizers for their blistered faces with N95 to psychosocial counseling from our PGH Cares team, and of course our gratitude goes with a very active chaplaincy led by Father Lito Ocon, going to the different areas of the hospital in their PPEs as well, ministering to patients and to healthcare workers in need of spiritual care. So as a more definite identification of how we can help our healthcare workers, our psychiatry department conducted research from June to July last year, and among 571 participants, we were able to identify stressors, which they mentioned as, and I got the top 3 of those stressors. The first one being, again, very admirable. The one stressor is that if that being negligent with their work, that they endanger their co-workers. They're actually thinking of others than themselves as one of the stressors when they work. Of course, our frequent modification of infection control procedures, which at the start of the pandemic was probably every 4 hours or every 6 hours. we'd issue a directive and change it half a day later. So that's how bad it was at the start of the pandemic. And of course, the discomfort of the personal protective equipment, which we were able to remedy by bringing down PPE wearing to 4 hours by adjusting the flow of personnel and patients in our COVID wards. To help us understand also how to remedy these stresses, I think they really appreciate the provision of food and vitamins. Again, a lot of help from our donors, and I think some of the food that they got during the pandemic was very, very uh, um, exotic ones. Some of them that they tasted the first time, but they still welcome as a welcome change on their daily routine. We gave them a 1 week off after serving the COVID ward, and then they appreciated that sufficient rest. And I think just all of this gesture of support somehow makes them feel uh, more less stress in their work. And of course, we see to it that they know that we are there with them, and we do daily rounds with them in their workplace. The other lesson that we found out is even in a high risk, high volume place like PGH, COVID transmission can be controlled and almost gone down to zero in our daily census. And I think the protocols implemented and adjusted as the needs arise have proven that. I always mention to everyone that even if the numbers are going down, even if the vaccine is coming in, we should never let our guards down. That's another lesson. We should always be a step ahead. I think that's the role of administrators. The administrator should be reading signs from left, right, top, bottom, front, back, and and find ways to be a step ahead of the problem. Um, so even before we opened the more of our non-COVID facilities, we already decided on testing patients and watchers. So we make sure that the healthcare workers are protected from the community. We made sure we found ways to get the shortest possible time for our results, and thanks to the Department of Health, we were given gene expert units for us to, and if done properly, you can actually get a result in an hour and a half. We always had our safety officers strictly enforcing the protocols in and out of the wards. Our hospital infection control unit is very aggressive and very systematic with contact tracing. And of course, the crisis committee meets every week to adjust and realign and recalibrate our strategies, such that maybe just to mention an information here, is that through all the thousands of patients that we have seen, both in COVID and non-COVID, there's only one transmission of COVID from a patient to a doctor, and this is even in the non-COVID ward, in a patient probably that came in negative, but eventually probably was already harboring COVID infection and started to have respiratory symptoms and had to be intubated. And this was the aerosol generating procedure that came up. So unfortunately, the doctors who had their guards down did not don the proper PPE. They continued to run the code in their level 2, and I think that's where the break came in. So now everyone is supplied with its own backup level 3 like this. Our interns are also trained to don level 3 PPE just in case in their course of duty they meet a situation like this. The communication is a key to all of this. It should be well thought out, timely, and I think we all should have just one voice. I remember if PGH is going to be asked to comment, I would call the Undersecretary Vergere to ask her if my statements will not be counter to any of what DOH will say. So I think that prevented a lot of miscommunications from people working in the COVID crisis. Um, People should be able to identify with the messages that we sent. So we made them attractive, easy to understand, colorful, and of course, very informative. We had a command center for patients coming in, calling in for questions and consultations. And we had a COVID transfer command to transfer patients to PGH and out of PGH using our emergency medical system. So we were communicating within the hospital and with people outside. And lastly, I'd like to remind everyone that, of course, although COVID is still here, there's still life beyond COVID. We have resumed our services, and we are now really happy. I feel so normal seeing my students back in the wards, and I'm seeing them assisting me in the operating room. And we have graduated almost all our residents except for four departments. And right now we have repositioned our lenses to assessing the collateral damage of COVID, and we're aiming for a COVID-free ward. So just to give an example, when we checked on our brain tumor patients in the neurosurgical service and asked them to start coming in, we realized that 12% have died already from the progression of the disease. So this is what COVID has done. Our infection, the bacterial pathogens now are more aggressive and more difficult to control, to treat, as a result of the rampant use of antibiotics in the COVID crisis. So I think there's a lot more that we have to look at now, with one eye on COVID and another eye on the other problems. This is how COVID has affected our operations. We are not even half of what we were before, but I think we are on our way to getting there in terms of surgery, admissions, and now ward bed allocation. So from less than half of in July, we're now up to almost 85% non-COVID. So this is our admissions showing an increasing trend. And as a final blow to the COVID crisis, we would like to, we are now building a 44 bed complex with 11 ICU capable beds in this behind our wards, one of our wards, which should be negative pressure with ventilated exhaust, with filtered exhaust ventilations. So it will hopefully will be up and running in 1.5 months time, so that we'll make the rest of our operations in the pavilions really COVID free. Of course, doing all of this, we are preparing for the vaccination that we hope will be rolling out soon. So thank you very much again, and sorry for the technical glitch, but I hope we've shared with you vital lessons that we've learned through the 11 months. Thank you very much.
Thank you very much. Thank you very much, Dr. Gap, for sharing the PGH experience of being a COVID-19 referral center. I see many questions coming in already. We will have our question and answer portion later on. I'd like to say hello to Joseph of Okun School, Magsaysay, Alicia Isabella. Hello. Good afternoon. And hello to the Amando C. Cope Memorial Hospital in Tabaco City, Albay. There was also another viewer from Bulacan Medical Center. Good afternoon to all of you. Before we move on to our next speaker, here is my first question for our contest this afternoon. Question number 1 is, in what month of last year was PGH designated as one of the COVID-19 referral hospitals in the National Capital Region? Don't forget to like the Facebook page of Philippines Graphic before sending your answers. And we need all 3 answers to the 3 questions. Please don't forget that. Okay? So let us now move on to our next speaker. This doctor, an infectious disease specialist, was the one who spearheaded efforts to transform the medical city into a safe zone for all patients. Let's all welcome Dr. Carl Evans Henson, Director of the Hospital Infection Control and Epidemiology Center of the Medical City. Dr. Carl, good afternoon. Mute si Doc
Works.
yan. Okay. Hi, Doc.
Yeah, can you hear me?
Yes, Doc.
Yeah. Magandang hapon po sa inyong lahat. Let me just share my screen. Can everyone see my slides?
Yes, Doc, we can see them.
All right, great. Sige. So let me start. I was told I have 15 minutes to talk about how we transformed TMC into a safe zone for all patients. These are I have no disclosures for this talk, and this is my outline. I want to talk about TMC's preparations even before the pandemic happened, and then how we transformed TMC into a safe zone for the staff, the patients, and the community. So before the pandemic started, we had what's called the Epidemic Rapid Response Team. This was born out of TMC's experience with previous pandemics. So the infection control director before me, Dr. Tyson, had experience with SARS and Ebola, etc. So yung preparations for Ebola and the policies in place for the ERRT was because of the accumulated na preparations for those global communicable diseases. It is also part of our requirements for the Joint Commission International, to whom we submit for accreditation every 3 years. Now, the ERRT is a multidisciplinary team. Meron dyan nursing, security, corporate communication. So basically, almost all of the departments in the hospital are involved in this team. No? As part of our preparations, kasi nga, iniisip Ebola. No? So, um, we keep an airborne isolation unit in working condition outside of the ER. The idea is, if may pasyente na isa, doon ipapasok sa airborne isolation unit. No? But we realized now a weak premise because when COVID happened, it wasn't just one person. No, it was really groups of people coming in. As part of our preparations, also we were doing annual mock drills, and our nurses in the ER get trained in donning and doffing of hazmat. So coming into the epidemic, we really did, we weren't starting from zero. We're all familiar with the general timeline. I think by this time, December 31st, we were hearing reports from Wuhan of these unusual cases. I convened the ERRT back in January 20, when there was already some news that the 2019 nCoV pa nun, had spread out of China. But 10 days later, on January 30th, we had our first Philippine case that was reported. Now, if we remember, this was that Chinese national in our ITM. And a day or two later, that Chinese national had died. We got our first case in Medical City, February 8th. We were seeing COVID suspects back in February, pero they all turned out negative. But our very first case was on March 8th, and I think that was really when things changed for us. So the very first question for us was, how do we keep the hospital as a safe zone for the hospital staff? That was when we got our first patient. That was the very first question, and what I really thought was my primary concern. How do we keep the hospital staff safe? Dr. Gap in his talk mentioned about level 1, 2, 3, and 4 na PPEs. And Dr. Nina Burba also practices in Medical City. And I heard the 1, 2, 3, 4 levels from her, and we adopted this from PGH. No? So we assigned which level PPE in which area. So pag COVID-19 area, definitely level 3, level 4 yan. And then kapag clean area, level 1 and 2. The main reason for this is, especially in the early part of the pandemic, we were short of PPE supplies. No? So the leveling of PPEs really was to help to rationalize the use of PPEs and preserve the N95s and the gowns for those who really needed it. Also, because I mentioned nga na there was a severe shortage of N95s, we had to recycle some of our N95s early on in the pandemic. So we set up a room in one of the patient units, no? And in this picture, you see parang may mga hangers dyan, mga hooks. That's where we hooked the N95s. And then we placed a silver impregnated hydrogen peroxide mister in that room, misted it for about 10 minutes, na, and then they came out clean and sterilized. So we were able to recycle our N95s and our coveralls that way. But eventually, once the stocks of N95s and even reusable respirators somewhat normalized, we were able to purchase reusable respirators for our nurses. Now, this is recent data. This is the number of employees, nurses, techs, etc., in Medical City who got infected with COVID. As of last count, we had about 500 plus 550, I think, na employees who had gotten sick with COVID. 28% lang sa kanila yung potentially from patients. No? It's really not, we can't really definitively say, but when we look at the risk factors and the level of exposure, so we say that about 28% of them possibly got it from patients. Now, community transmission, meaning they got it from their homes, from their dorms, etc. About 34% of the employees. And then 22% got it from co-workers. So if you will notice, co-worker transmission, ibig sabihin yan, mga kausap mo sa opisina, etc. So if you will really think about it, about 57% of transmission is still community-based, co-worker plus community. And I think that's an important important piece of information for our employees to realize. I'd like to cite an example of one of the outbreaks that we had in Medical City. So this was our network graph of all the people who got COVID and who got tracked or traced for COVID. The blue ones you see are the positive cases. So for example, this blue case right here has had contact with this many people. I'm referring to that circle right there. So yung mga green, yung mga na-test pero negative. So I encircled a section here where ang daming blue. So this was an administrative office in the hospital. Someone got sick and continued to go to work, and then he passed it on to her coworkers. So about, I think, total mga 14 people got sick from that one person. Fortunately, they were all mild cases. But what did we learn from this outbreak? So what we did was to give everyone the weekend off. They emptied the office. Nobody came into work. We did terminal cleaning of the office, placed alcohol dispensers on all the desks. Sabi ko, kasi parang dati it was really on entry, but I told the manager that there needed to be dispensers all around, because if you don't see the alcohol dispenser, people will not be reminded to clean their hands. This office was also rather very cramped. They had a lot of documents and folders, so I asked the manager to clear out some space to allow for physical distancing. We were doing symptom-based testing usually, but for this outbreak, we tested all the employees in the office, and we formed 3 teams. So one team came to work for 1 week, and then they went on break for the next 2 weeks as quarantine. We weren't doing this for the other units of the hospital. So for this particular outbreak, we did 1 week on, 2 weeks off, to wash out the COVID infection. And then after that, the outbreak was controlled, and they learned their lesson. They started always washing their hands, etc. So what are the lessons from that outbreak? These are strategies to minimize impact of quarantines. If you're the manager, you really need to know your staffing requirements and what the bare minimum is. Because if, for example, you identify your office as fitting the criteria of what's called critical infrastructure workers, ano ibig sabihin nun? People who absolutely need to be in the office or in the hospital, no? It's possible to modify quarantine guidelines for them. No? So um, because you need to make sure that the hospital is running. So what we did, if critical infrastructure workers, if low risk or moderate risk exposure, we want them to continue working. We monitor their temperature and we screen for symptoms, face mask at all times, and then we tested them 5 days after exposure, etc. And then if they develop symptoms, quarantine. Consider canceling non-essential procedures or tests as well to minimize the number of people who come to work. All right, so some important points for this particular outbreak. We need to remember that for healthcare workers with high risk exposure, those who go to the COVID units, the issue here is proper donning and doffing. Um, Sometimes nalilimutan yung proper procedures for putting on and putting out, removing the PPEs, and sometimes you can get infected that way if you're not careful. The numbers for TMC, about 28% of healthcare workers who got sick might have gotten it from sick patients. And really, all these people, most of them got sick earlier on when there was really a low index of suspicion for COVID. Ito yung hindi pa tayo masyadong hahanap ng COVID, and some of our patients got identified in the regular wards. But this number definitely dwindled down once we had COVID front and center in our consciousness. Community transmission is about 57% and is still the most common mode of spread. So ito yung magka-opisina, pwedeng administrative office yan. Dahil na-miss yung isa't isa, they were eating together, sharing their sausawan, etc. Yun, nagkaroon ng outbreak doon sa office. It's about 57%. So after we had made sure that our staff were safe, we also had to make sure that the hospital was a safe zone for patients. Actually, we were doing it in parallel. But immediately after we first patient, syempre ang iniisip ko, the healthcare workers needed to be protected. But the patients also need to be protected. And this included both COVID and non-COVID patients. So the MMWR or the CDC is saying that 4 in 10 US adults reported delaying medical care because of COVID. And for a while, people really weren't coming back to the hospital. And we're sure that this resulted in some higher morbidity and mortality for our patients because, people with heart conditions, they don't go to see their doctors, etc. So we came up with what's called a 2-in-1 hospital. I think that's where the title of my talk came from, a safe zone for all patients. So we installed triage desks in all entrances. Initially, these were manned by nurses. We had to proportion some of our nurses to go to these triage desks. Medical City is also fortunate in that we have 2 emergency rooms. One smaller emergency room was before COVID was a pediatric ER, and then we had the bigger main emergency room for adults. So when COVID happened, we had kumbaga we could separate the ERs for the 2 kinds of patients. And I think that worked well for us, kasi physically separate, and patients were more willing to go to the emergency room for a non-COVID complaint because there was a separation. We also separated the admission counter for COVID and non-COVID. We installed an admissions counter in our wellness area in the 6th floor to take care of direct admissions for non-COVID cases. If the attending physician said this was a non-COVID case, nakasulat siya sa admitting orders, then pwede siya doon sa clean admission, yung sa non-COVID admissions office. We had separate entrances, hallways, and exits. Of course, all hospitals will have this, so dedicated COVID-19 units and transition rooms, dedicated elevators for COVID patients, and of course, dedicated staff. Other interventions, Dr. Gap already mentioned about, dati ang tagal ng PCR, tapos very precious siya, no? You couldn't get one if you only had mild infections, no? But, as we progressed in the pandemic, there were more PCR machines, we hired more med techs, and then we did some physical improvement in our lab, resulting in faster turnaround time in our RT-PCR tests. And I think this really helped because patients who had respiratory symptoms, for example, had to be admitted to a COVID unit. Pero turns out negative pala sila. Some other condition pala yung kanilang respiratory problems. We were able to move them out of the COVID unit faster because we were getting our PCRs faster. We also worked with operations to make sure that room cleaning turnaround time was faster as well, and there was tighter communication between nursing and housekeeping. So those little things, when you add them all up, there was really just more efficient way of moving in patients who were suspects into their rooms, and then once they were cleared or they were discharged, cleaning out the room and then allowing that room for use for the next patient. Also, the third thing that we had considered was, so we've kept the hospital safe for patients and also for the staff, no? But we also wanted to do our part for the community. Medical City, the community, the Medical City's community involvement in Pasig even predates COVID. We had worked with the Pasig City Mayor with his community health programs. Now we had Medical City adopted several communities in Pasig, and we sent some of our residents there to take care of the community there. No? So moving into the pandemic, it was really just natural for us to continue our partnership